Hello and welcome to the New Indian Express Online. I'm Bansi Kadapa. With me is Director of Kidwai Memorial Oncological Institute, Dr. Lokesh. Welcome on the show, Dr. Lokesh. First of all, there is this word that is being used increasingly called Indian cancer. Now we understand Indianness about other things, but what is Indian about cancer?
See, what we have to understand is, in our country, the total number of new cancers that we deal with per year is about 12 lakh new cancer patients for the whole country. And then when we look at our state, we are looking at a burden of some 70 to 80,000 new cancer patients in the state. And these are the new patients who develop cancer, not the prevalent ones. So the kind of picture that we see when you look at the Indianness of the scenario, we are looking at a bulk of the cancer patients being tobacco related, and more than the smoking type of tobacco, it is more of chewing type of tobacco that contributes to the adverse health effects in our population among both men and women. And the contribution of chewing tobacco is to the bad effects and contribution to generation of cancer is especially seen in oral cancer, head and neck cancer, throat, and other areas which are having a huge health impact on the patient and their family, and also having a huge economic impact at the same time.
Okay.
And also when we look at the current trend, so what is happening is we are also seeing there's a change in trend of the cancers. They're becoming more westernized in our population. When we look at in the female, previously cervical cancer used to be the commonest cancer and it was leading. Now breast cancer is taking a lead role among women. But the Indianness, or in the Indian scenario, what we are seeing here is many of these cancers are seen in younger generations, like maybe in the third
For example,
decade.
in the West, when we see in UK or France or Germany, in the Western world, you see incidents of cancer, especially among those who are in their 70s or 80s or 90s. But here, when we walk into hospitals, we see cancer patients who are just in their 20s or 30s or 40s.
Yes.
What is this?
This is the there may be certain amount of genetic factors that are involved, and the immune system that plays a key role in the generation of cancer is something that we also have to study in our population. And also what we are seeing is when there is a cancer that generally there is a natural history how a cancer develops. So it develops from stage 0. By the time it becomes 1 centimeter thick, so it takes about 10-15 years, for example in breast cancer. So naturally somebody elderly women develops cancer, a 1 centimeter tumor would have taken about 10 years to develop, 5 to 10 years, but it becomes symptomatic in maybe last 3 months or something like that. So, but what we are also seeing in our population is the occurrence of younger age group at which the cancer occurs. There is a aggressive behavioral pattern, and the cancer tends to be more aggressive and tends to spread much faster. And this is something that we are seeing in our population.
Is there also something which is more specific to southerners, northerners, something more specific to eastern India?
Certain pattern used to exist. Now because of the huge intermixing, you may not see that kind of a major changes happening, because what happens is the documentation of cancers in the population registry was more robust in the southern states compared to the northern states. So
thanks to the administration.
Example was like Kidwai, Adyar Cancer Institute, RCC Trivandrum, Tata Memorial. They're all in the southern and Hyderabad. So these centers, which are regional centers, in the last 30 years, they developed solid foundations and they created hospital registry, then population registries, based on which the ICMR also has its base in Bangalore. So originally ICMR for cancer registry started in Kidwai. So a lot of our scientific input has gone into the documentation and how the data is collected and how the data is screened throughout the state. So, and the same thing is used across the country. So, we are seeing good trend across the country, people recognizing where underprivileged are covered from healthcare and all those things. Now it is reaching the different zones across the country. So this scenario we are seeing, but in the state also, our government has made a lot of efforts, and then they supported us in every way. We asked for equipments, they're given. We asked for manpower, they're given. So when we proposed the needs of the state, and then how the state should be able to give healthcare across the different parts, districts of the state. So, because cancer care is something not like where you have a small infection and it gets treated in a day. So, there is a time course of investigation which generally takes about 2 to 3 weeks. And by that time, the staging would have occurred, and then there is a solid pre-plan how the cancer has to be treated, sequencing of surgery, radiation therapy, chemotherapy. All this has to be pre-planned and executed. And this is very important because we are moving into an era where in the future the treatments will be more based on genetic makeup of the cancer, on the patient's genetic makeup, and how aggressive we have to be in terms of our treatment, tailoring the treatment, nanotherapies. So these are something that is where we should plan at this point. If we pre-plan these things now, 5 years down the line, 10 years down the line, we'll be able to deliver appropriate healthcare to our population. If we lose at this point, we will still be delivering low quality care at that point. So it is very important that we solidify our scientific foundations, put our footings very strongly, get the team in place, get them exposed to what is happening in the West and things like that. And we should be pre-planning what should be in our healthcare centers, especially the oncology healthcare centers, 5 years down the line. What should be the pre-planning and how the team should be kept ready. This is what should be happening, and we are working in those directions.
Okay. Now, also when you see COVID, the pandemic which hit the world, now we've heard from many that COVID has increased the incidence of cancer. Does it make any sense?
There are so many reports that come and go. The kind of impact reports that you may see can only be evaluated 10 years down the line or 20 years down the line. At this point, there is nothing strong that says COVID can increase the incidence of cancer, because it's one of the virus which, but genetically what happens is, evolutionary wise, there is something called genetic archaeology, which people do. And then many of the immune system, the genes where the immune system tells the body, kill this virus, kill this bacteria, they were actually originated archaeologically into the human genetic genome. It was incorporated billions of years ago. Genetically it is incorporated. Viral segments are, the same segments are there which actually defend us. So these are all part of the evolutionary process. So, but from the common perspective, what would probably happen in the scenario where people were confined to the houses and all that, there might have been certain amount of sedentary lifestyle and change in the kind of food, more westernized food, packed food, things that might have just made slight impact, which people should take cognizance. But COVID as such, at this point, you cannot say it causes increase in cancer at this point.
Now, also, there have been complaints from certain people. This has been on social media also, that so and so has taken the vaccine. Does taking the vaccine, is there any impact on the incidence of cancer? Is there any relationship?
At this point, there is no attributable risk to the COVID vaccine to increasing cancer. So what will happen is there were different variants of vaccines that were used across the different parts of the world. So what will happen is these populations will be studied for 10, 15 years, 20 years down the line. And then only when you have a solid data and pure data of the type of vaccines that were given to the person, and then only you can make an impact assessment. The only trade-off that I see is when we look at Covaxin, Covishield. Covishield is basically a chimp adenovirus, which was used as a carrier to deliver a segment of the DNA of the that will generate spikes inside the body of the human. So this concept of using adenovirus, this adenovirus is a mild virus which are used for virology, human experiments to study immune response and things like that. These are used on commonly in Western countries on students. They get exposed to the virus and they study the immune response and things like that. And then it doesn't cause any major infection. So the adenovirus that was used in Covishield, actually when you look at being able to deliver a small segment of DNA to do something is actually a part of gene therapy. Okay. So by principles of gene therapy had been proposed for cancer. So what will happen in future, the only trade-off is a younger generation had got, we'll assume, some 20-year-old kids got Covishield, we'll assume. 20, 30 years down the line, if there is a gene therapy that has to be delivered for some cancer for this kid who has grown now as an adult, at that point, the adenovirus cannot be used as a carrier for gene therapy of that cancer. So then by that time, they have to find some other virus to use as a delivery method. So, but in the other advancement that has also taken place is the mRNA vaccine was a nanoparticle. So the nanoparticle, they use a small segment of RNA with a small nanolipid as a carrier, and that delivers the RNA inside the cell. So this method of virus vaccination also they will be studied in long term, because there are a lot of at micro level, what happens to these nanoparticles that were injected into the patients, that people will be studying long term, how it gets thrown out of the body, those things they are studying. So alternative to the virus as a gene therapy, they have also come up with the nanoparticles, okay, to carry the genes. So they may use those things in future. So this is what I feel. But once a gene therapy or kind of a concept has been introduced, always this scrutiny of impact on cancer will be there. So only thing is the population studies have to be robust, and once the data is systematically collected and analyzed, then only they can say, okay, this vaccine caused this problem and all that. But the virus as such had its own impact on the normal tissues of many people in the population. So the once it affects the lung, once it affects different parts of the body, so there is a different architecture within the body. So those zones, are they going to have an increased incidence of something, is what only an observational study will reflect at this point.
Now also Kidwai Institute there are new advances.
Yeah.
This is as regards bone marrow transplant or nuclear medicine. Is there
Yeah.
something that is at the cutting edge that's happening now?
Yeah. See, I'm proud to say in Kidwai Memorial Institute of Oncology, we are the first government center to come up with the allogenic bone marrow transplant. So this is something like kidney transplant. But there is autologous bone marrow transplants with more than 35 patients we have done, and literally we have treated these patients free of cost. So there we use some government grants, and then we resource from our own donations and try to do treatments literally free of cost to the patients. And there are many things which are under my control, which I can facilitate the doctors. So what is like now our strength is we have been able to do allogenic bone marrow transplant also. This will help people get transplant for various non-malignant disease also. So what we need, what is happening is we are trying to strengthen the team, and then there is the next level is like how you do gene the haplotype matching and things like that for the kidney transplant. We are moving into allogenic transplant zones where even if there is no match, you can still do a transplant. When this is being practiced abroad, and we need our team to, we have actually sent one of my team member, I sent him to UK. We are waiting for them to come back, and then in the meanwhile we are also implementing the we are tying up with some US centers and collaborating with their protocols. So we are implementing the latest allogenic bone marrow transplant also, using total marrow lymphoid irradiation, also for priming the patients. So there will be a lot of lesser side effects. That is what we are doing. And also we would like to introduce something called CAR T cell therapy. So these are the advanced things where the immune system plays a major role.
So all this is happening not in the public health space. It's happening in
the government sector,
space,
where the government,
it's not in the private.
The government helped us, and whatever projects we wrote, they approved, they helped us, and then we just need small manpower, which we are working on that. And then we also need to train them, and then also support them. So which in the last few months I was able to kind of put the team in place and make them do these things. So we plan to aim something big that will be given at a very low cost to the patient, and then maybe the international patients can come and take treatment with us. So my team is kind of positive on those modes. And then radiation facilities on European standards. We do permanent implant brachytherapy, which no other government centers do. And then we have brachytherapy suite, which even the doctors from US, when they came, they were surprised. Even our bone marrow transplant unit, they were surprised we had that kind of a facility. So we planned where we should be, and then where our healthcare should be going. And then when it comes to the nuclear medicine, this is the next level of what happens is when it comes to chemotherapy, there is a huge expenses that go. So we are trying to tie up with Western government research groups, so that the good funding is there for the research also. So our patients will be able to get the latest drugs, the latest thing, anything that happens new is there with us. That is what I have in mind, and we are working. We have been continuously having meetings with the University of Arizona, so many other universities. And then because we need the team, it's ultimately cancer care is teamwork, and we have to give proper direction to the doctors. Their job is to think how to cure more patients. So that's where, and from administrative point of view, we have to support and also take them where things are not on the, and stand by them and we do what is required for the patients. And because we serve the poor, so our mindset is like that. When it comes to nuclear medicine, the next level is radioactive therapies. So if there is a disease that has spread across the body, there are radioactive isotope therapies that can be given. So we are working on trying to get a cyclotron into our system where we can generate our own radiopharmaceutical. So because what will happen is the isotope scans are expensive outside, but in Kidwai we are able to do at a lower cost, at one fourth of the cost than the private sector. So we have been trying to do what is good for the patient and trying to match the European standards. Our probable tie-up with the US centers will put us in a little more higher quality zones,
Okay.
because we'll get audited by them. That is the advantage.
Thank you, Doctor.
Thank you.
There it is, Dr. Lokesh, Director of Kidwai Memorial Institute of Oncology, telling us that this institute, although it is a government institute, is doing things which even private sector institutes are not really doing. With camera person, this is Bansi for the New Indian Express Online.